All right, so first thing we're going to do is remind you all about math. I know. I saw some stank faces. That's not what I wanted. All right, what are you guys seeing?
White.
A lot of white.
A lot of white. Fantastic. Not the right screen. Thanks a bunch, Zoom. There we go. That should be better. Cool.
Drug math.
Drug math! Everyone's favorite. There we go. All right. So drug math is kind of super important because most of the time we have our standard dosage for things. For the love of God. I can't with this today. Hold on. Hi.
I'm making a sandwich.
What? I'm in the middle of class. Quickly, please. I'll call you back. All day on the phone. All right. So we have our standard doses of some things that we give, like albuterol, right? It's a unit dose. We open up the container, we give it. EpiPens, we just, provide the EpiPen. But there are times when you're actually going to have to do drug math, right? So sometimes drugs are not packaged in single dose. Sometimes you have, for example, an ampule of Epi 1 to 1000. If you have to do the check and inject, you need to make sure that you're drawing up the right medication amount so that you don't cause all sorts of other issues. Sometimes you have to make your own medication. For example, magnesium, right? So you take 2 grams of mag and put it into a normal saline bag, or you will take amiodarone and you'll put it into a normal saline or a D5W in order to administer it, because sometimes medications are really mean when you give them straight up. Amiodarone is very painful when it's done in a bolus, which is why we only give it to the dead. So there's just a lot of things that you need to make sure that you know, and this is where we're going to teach you. So, there we go. Don't panic, okay? Everyone gets really kind of panicky and nervous about math. I know you may have had poor experiences with math in the past, but this is all relatively basic math. It's a little bit of multiplication, a little bit of division, but it's nothing really going to stretch it's not college calculus, okay? So let's take it one step at a time and we'll work through it together. Different routes of administration that we deal with, that you also need to kind of know how they work, right? You have intramuscular, or IM, where you're injecting the medication at a 90-degree angle into a muscle body, commonly the deltoid or the thigh. Subcutaneous, it is in protocol that subcutaneous can be used for epinephrine administration. We do not use that in New York city area, but other parts of National Registry, if you might see, how would you give epinephrine? And the only correct dosage is paired with sub-Q. That might be your correct answer. IO and IV, right? Very similar on administration onset time, so that it's very, very fast. Other abbreviations you might see is IVP or IVB. It's IV push or IV bolus, right? So that's when you're giving just a dose of medication one time via an IV and then flushing it thoroughly. IN, we're all super familiar with IN, right? We have the Narcan that we like to use. Sublingual, right? Nitro, that's our common medication that we give sublingually. Very rapid onset. It goes right through the mucous membrane of the mouth in order to do what it needs to do. Buccal, right? That's in between the cheek and the teeth. Oral administration is your oral glucose, right? You eat it and then it's digested and it works effectively that way. Transdermal, the patches, right? Back in the day, they used to use nitro patches, right? They make a nitro paste patch and put it on a patient instead of giving them sublingual nitro. We do have some ocular medications, right? We have tetracaine, right? So if you have a patient who has an eye injury, you can provide them with some pain relief. rectal administration is still approved for rectal diazepam for pediatric patients. We don't see that very often because it's kind of traditionally we go with IM instead. Just remember, if you ever do need to administer rectal medications, to take the needle off of the syringe before you do so.
When I worked in a group home, even with like the adults that were behavioral, a lot of them still had like the diazepam prescribed to them rectally. So God forbid if they had seizures at any point, you just whoop,
yes,
and just give it to them that way.
Yeah, that's where you'll see it a lot if you ever work in an area that has a bunch of group homes. Rainbow Commons in Melville, that kind of area, they use the rectal diazepam a lot. Thank you. Nebulized medication, right? We're all very familiar with that. Easiest way to make humidified oxygen is to take a little normal saline and throw it in your nebulizer if you have a patient who really can't deal with the dry air. So we use the metric system when it comes to medication dosages, okay? So everything that you're going to do is commonly most medications are in milligrams, but you're moving along this metric system scale. So, when you're looking at different things, you should expect to see them in different sizes, right? So if you have a patient's weight, you're going to expect to see it in a kilogram. Certain medications, right, like your magnesium and your calcium, dextrose, is measured in grams. Most of your other medications like aspirin, Narcan, etc., are in milligrams. You have micrograms like dopamine, norepinephrine, fentanyl. And then you have your bicarb. Sodium bicarb is in a milli equivalent because it is not technically like a drug. It's a buffer. It's a naturally occurring thing. So because it's the OH and the hydrogen ions, that they measure that in a milli equivalent. It's super easy to convert in the metric system. You're literally just moving a decimal over. So if you're going between a gram or a kilogram to a gram, every number that you have in the world, this is basic math concept, has a little decimal point right after it, okay? It's invisible. We don't traditionally have used them unless it's like an actual decimal, right? But it exists. It lives there. So if you have a kilogram and you want to make it into grams, you are going to take that decimal and you're going to move it over 3 places. And every place you move, you're going to add a 0. So if you look down here, you might see my cursor. So if you just look without the zeros, the 1 kilogram, right? So then move it over 1, 2, 3. That invisible decimal goes away again, and 1,000 grams is equal to 1 kilogram. And that is the same as you continue moving down. So that if you're here, you're looking at 1,000 grams is one. You move it over is 1, 2, 3 is a million milligrams. Okay, and it continues over. So that's why when you're like, oh, I'm taking 1,000 milligrams. If you're taking 1,000 milligrams of like vitamin C, for example, that's 1 gram. Okay, does that make sense? So 1 kilogram is 1 million milligrams. And it keeps getting exponentially bigger by 3. So that's a lot. What's that, a billion? A billion micrograms is 1 kilogram. Does that make sense?
Comprende.
Okay, taking the silence as understanding. Same thing happens with volume, right? Your milliliters. So 1 liter bag, right? If you ever go in the ambulance and look at this, 1 liter bag is 1,000 milliliters. Okay. Half a liter is 500 milliliters, right? 500 milliliter bag is a half a 1 liter bag. The cc. Sometimes you'll see this. They like to use this abbreviation on occasion. The cc is equivalent to 1 milliliter. Okay, cc is commonly used in like those syringes, like those the ones that have like the little for the little kids when you're doing like the baby Tylenol and it's got the little suction cup bit on the top. There's often measured in cc's. teaspoons, like those, that kind of thing. It's more of a like a kitchen kind of concept, but is equivalent to 1 milliliter. This is essential. Gym rats, you should get this. 1 kilogram is 2.2 pounds. Okay, you're going to see this a lot. You're going to be doing a lot of conversions of patient weights in order to do medication math. And I'm going to show you, there's a lot of different ways that people do it, like for themselves. You're going to memorize some certain milestones. We're going to call them milestones, okay? Super easy, right? We're talking about decimal places. We can move them over. So if you move that over here, hold on, let's go back. Hopefully we can go back. Nope, little thing's in the way. Oh wait, hold on. Right, 1 kilogram is 2.2 pounds. If you take this decimal point and move it over 1, that means that you've multiplied by 10. So that means that you can take this here, move it over 1, and that's 10. So 10 kilograms is 22 pounds. Okay, because we don't really usually see 1 kilogram. Hopefully we're not seeing 1 kilogram babies, right? That's the Presby baby bus. We don't get paid enough for that. So just if you keep that in mind, it gives you a good reference point. So if you're ever like sitting on the truck and you've totally brain farted, you're like, oh no, I don't remember how to convert this, and I'm not able to do division right now because my adrenaline is pumping. Go back to 10 kilos is 22 pounds, and then just add 22. Okay? Every time you add 22 pounds, it's another 10 kilos. Another way you can do it is you are going to divide. Okay? So again, you can't divide a decimal. So what you're going to do is in order to divide this, you move this over, and what you do to one side, you do to the other, right? So that's right here. So 2.2 becomes 22, 110 becomes 1,100, and then you divide. Okay. Questions, thoughts, concerns?
Nicole, this is a very simple explanation, but the question I had was for test purposes. I know we're not going to be able to do it on the back of the rig, or maybe we will. Can we use a calculator in the test when we get to that complex math? Are you going to expect us to use these techniques?
I would recommend using these techniques because the state will
Right.
not allow you to have a calculator.
Got it. Okay.
Okay.
Good to know.
So as long as once you get on the truck, you can do whatever you want. Though I do recommend taking your gloves off before touching your phone for the calculator. But you can do whatever you want. And I highly recommend using a calculator to check your math, because if doctors can do it, there's no reason that you as a paramedic should not be doing it. But the state does want you to do, to prove your competency with basic math to a certain extent.
So then along those lines, for example, when we're taking the test in class in the new proctor room or in the state exam, are we allowed to use a worksheet?
Absolutely, yes.
Okay.
Because you should have scrap paper when you are taking the test.
Okay.
Though I would like to see everybody's, like that meme where they're doing math in their head. I want to see everybody's math face. I'm looking forward to that, not going to lie. All right. Other little weird kind of thing that I've noticed when you're doing this, the pounds to kilograms conversion, and that would mean that you have to memorize these particular the poundages over here, okay, from like 10 to 100. If you take out the middle number and divide by 2, so 110 becomes 10, divide by 2, it's 5. Take out the 3, 12, divide by 2, 6. Okay, that only works for these benchmarks. Okay, just if you are having a total brain fart and need something to kind of jog your memory, that might help you a little bit. So when you're giving medications, right, you want to know what you want to give, how you're going to give it, and what do you have to give. Okay. Most of the time, the what do I want to give is what protocol am I working under, right? What's the most appropriate medication for this patient? How am I going to give it, right? Is it going to be IV, IM, intranasal? And then what do I have to give? Okay, so how much medication are we going to actually give at the end of the day? your desired dose is important to know. Okay, so this is part of also memorizing your protocol and understanding what your standard medication dosages are. So if I say I want you to give a patient amiodarone, you should know that that's going to be 150 milligrams. That might be, when it's a live patient, 300 milligrams when it's a dead patient, right? That might be a bolus for the dead patient, or it might be diluted in saline or D5W for a live patient. Okay? If I say, oh, give that patient calcium, you should know that our standard protocol dose for calcium is 1 gram, and it's a bolus. Okay? So you're moving between two sets of knowledge, right? You're moving between your protocols as well as the clinical information that the patient, patient presentation is providing you. So this is the very beginning of the critical thinking part of paramedicine. So different desired doses, right? If your patient requires 4 milligrams of morphine for extremity pain, if they require 0.1 mg per kg of Zofran, dopamine is mics per kg per minute, okay? And it's a weight-based drug, so you need to also know how much your patient weighs. If your patient needs amiodarone and you're giving it to them for VTAC with a pulse and 50 milliliters of normal saline, right? So these are some things that you're going to need to think about, right? And this is where knowing your protocols is important. Morphine, right? Morphine is standardly administered in a bolus. You need to make sure that bolus is not, you're not slamming. Well, there's a side note, please don't slam your narcotics, okay? They do this in the hospital on a fairly regular basis, and they usually follow up all narcotics administration with an antiemetic, because if you push a narcotic too quickly, your patient will get nauseous, okay? It's a very common side effect, and if you are a nice paramedic, you will make sure that you don't cause that. In the hospital, they're not too concerned, right? They just like full on just here, and then they move on here. Here's your anti-nausea medication, and they just keep going. But this medication is administered via a bolus. It's potentially a slower bolus than you would give, Solumedrol or something. If your patient is 88 pounds and you need to give them 0.1 milligrams per kilogram of Zofran, the first thing that you need to do is make sure that you know how much that patient weighs, right? So 88 pounds is 40 kilos. And then you take 40 kilos and multiply it by 0.1, okay? In case people have forgotten how to multiply decimals, we'll go over that again in a little bit, and I'll write it out for you. Hold on, let's make a note to myself before I forget. Multiplied decimals. When you're setting up the equation for yourself, you're going to pretend that the decimal isn't there, right? So I know a lot of people like to do, like to line it up. If anyone Common Cores at me, I will slap you. Through the Zoom, I will slap you. There will be no Common Core math. Right, so let me see if I can actually, oh, hold on. Exit full screen. Let me see. You seeing a whiteboard? Mm-hmm. Okay. Right, so if you have a patient, come on, pen, there we go, who's 40 kilos, right? And you're doing 0.1 mgs per kg. This is going to be milligrams. No, this is kilos, just kidding. Kilograms, there we go. All right, so you're going to multiply this like this decimal's not here, right? So 1 times 0 is 0. 1 times 4 is 4, okay? You don't have to do the zeros on this side. So now you have one place that's after the decimal, which means that going back to that invisible decimal place here, you're going to move it here, right? You have to have it equivalent on one side and the other. So your answer becomes just 4. Does that make sense for everybody?
Yeah.
Okay.
Yes.
All right, cool. We'll revisit that a little bit. There you go. So if you have a patient, your desired dose, and you're doing dopamine, right? And the dopamine is a little more complicated than how to actually administer it. We will talk about dopamine administration in a presentation or so. If your patient needs 10 mics per kilogram per minute, and your patient weighs 220 pounds, right? You're going to convert. You can divide 220 by 22, or 220 and move the decimal place over. It's 100 kilos. 100 times 100, or 100 times 10, sorry, is 1,000. And that's going to be mics per minute because you've solved for how many kilograms are going to be, here's your kilogram. They cancel out. If your patient is requiring amiodarone, right? You're going to 150 milligrams of amiodarone in 50 mLs. That patient is going to receive a full volume, right? That full 50 milliliters, because it's containing that 150 milligrams. Okay, so yes, you're mixing up the medication, but you're still making sure that you administer the entire thing. Different routes, okay? These are the ones that we most commonly work with, right? Here on the bottom. Again, this comes back to kind of remembering what your protocols are and how each medication is expected to be administered. So are you giving a patient a single dose, or you're giving them a specific amount? So if you look at the medications that you carry on the ambulance, if you have a patient who needs Solumedrol, for example, that comes in a single dose vial, okay? So that comes 125 milligrams in 3 mLs. So you're going to give them 3 milliliters. If you need to give them epinephrine, and you need to give them 0.3 milligrams for an allergic reaction, that is coming in a 1 ml vial, right? So you're going to draw up 0.3 milliliters to give them the 0.3 milligrams. Then you have your drip rates, right? You have the medications that you're going to give based on a potential drip rate, right? That's going to be your dopamine, your norepinephrine, amiodarone, okay? These hang out here, and we'll talk about that a little bit more in depth. And then you have a specific volume, right? This is really where amiodarone falls into, right? Amiodarone, magnesium, right? I diluted my medication, and now I need to give this full amount at one time over a certain amount of time, okay? And it's going to be a lot more clear shortly, I promise. Dose on hand. This is how the medication is packaged, or you have prepared it, right? So we already talked a little bit that Solumedrol, right? It's 125 milligrams in 3 mLs. That's going to be your dose on hand. If you look at the medication boxes themselves, it gives you all of this information as well. So your dose on hand here for this adenosine is 6 milligrams in 2 mLs. So if you had to give a patient 6, 12, and 12, you're going to need 2 milliliters for the first dose, 4 milliliters for the dose after that, and another 4, bringing you for a grand total of 10 milliliters of adenosine for that entire protocol. Okay, so this is when we make sure that you have an adequate amount of medication on the truck. Things like nitroglycerin, right? If you see here, it tells you right on the box, it's 400 micrograms per spray, okay? If you look here, in every ml, there's 1.36 milliequivalents of calcium, okay? So just make sure that you're familiar with your medications, because sometimes, and this happens a lot in hospitals, a little less frequently on the ambulance, the packaging might change, right? All of a sudden they change to a different pharmaceutical company, and the purple vial is not, Benadryl anymore. The pink vial is Benadryl, and you grab the wrong one and give a patient the wrong medication, right? Or it's no longer packaged in 50 mLs of, 50 milligrams of Benadryl in 2 mLs. It's now in 1 ml. Okay, so just always make sure that you're looking at the things in your drug kit, because sometimes they do change. Now to the meat and potatoes. Solution concentration, this is going to be one of those things that you're going to learn, and then you're going to promptly forget, and then you're going to go to refresher, and you're going to remember it again. Okay, it's just one of those things. But it's kind of like at the back of your head. Actually, percent concentration is. So your concentration, right? So if this is kind of also, if you kind of cheat and learn to look at your boxes, your administration request is for 5 milligrams of diazepam IV push. Your vial is 10 mLs with 50 milligrams in it, right? So this is like a cross multiplication as well. Do you remember cross multiplication? Hold on. Go back to here real quick. So if you were asked to give 5 milligrams, I know algebra guys, algebra, of diazepam, and it comes in a 50 milligram 10 mLs. Okay. The easiest way would be to cancel out your zeros, but we'll talk about that in a second, because sometimes your math is not so simple. Instead, you're going to cross multiply. So I'm going to take this here, and I'm going to multiply it with the bottom number, right? So then you get 50, and then you're going to go the opposite direction. So you get 50x. Now you want to get x by itself. So that means that you have to divide x by 50. So if you divide by 50, right? So that becomes x becomes itself, and this becomes 1. Does that make sense?
Mm-hmm.
So that means that you're going to be giving this patient 1 milliliter of medication. So going back to canceling out zeros real quick, if you have numbers that end in zeros, right? And this is going to be really important when you get to dopamine. So we're going to review it real quick now. It has to end in a 0. I've seen people do like a patient's like 505 kilograms over 1,000 milliliters or whatever, right? You can't cancel out this middle 0. That doesn't work. Someone did that once, and I was like, your math is going to be janky. It has to be a terminal 0, okay? Because terminal zeros mean that there's a tenth, right? A tenth. It's been multiplied by 10. So that means that you can then divide by 10 to simplify. So that means here and here, it becomes 5 milligrams in 1 ml. Okay? I didn't lose anybody, did I?
No, you're good.
No, we're good?
Yeah.
All right. So we did that math on the other side. Gram percent. This is the one that you're going to learn how to do and then promptly forget, because I have to refresh my memory every time I teach it. It's important to know how, in some instances, it's very important to know how many milligrams are in each ml. I want to say dextrose is probably your most important aspect of that, because if you're carrying D50 on your truck and you need to give a pediatric a weight-based dosage and you don't happen to have your D25, you can make it work by diluting it, but you need to know how many milliliters of the D50 that you're going to mix with saline. It's one of those just in case things, right? So when you have a percentage, it means it's out of 100, right? So every time that you have a medication that's a 50%, or normal saline is 0.9%, you're going to take the decimal or the percentage off, and then you're going to say it's a ratio, right? So every 100 milliliters has 50 grams of medication in it. If you kind of look at the percent sign and you kind of turn it on its side, it could be like a 1, 0, 0, kind of jog your memory. The problem with gram percent is that it needs to be in milligrams to be more useful for you in terms of administering medications. So we go back to, the concept of moving that the 0 over 3 places to go from grams to milligrams. So 50, you get that in your invisible decimal point. You move it over 1, 2, 3, becomes 50,000 milligrams. Divide that by 100 to get how many milligrams per milliliter, right? And this is one of those spots where canceling out your zeros is going to be super helpful, right? So you have 2 zeros on the bottom and 2 zeros on the top. So that means that you're down to here, to 500. 500 milligrams per milliliter. Here we have a 0 or a decimal place in the front. We're going to move it 3 places, 1, 2, 3, to get 900 milligrams in 100 mLs. Again, cancel out your zeros and then divide by 1, which is the best, easiest way to divide. You have 9 milligrams per milliliter. Epi is sort of similar, except it's not in 100 milliliters, right? It gives you what the ratio is right here. Okay, so your Epi 1 to 1,000 is 1 gram in 1,000 milliliters, where your Epi 1 in 10,000 is 1 gram in 10,000 milliliters. So that makes your math a little more complicated in so much as you're dividing by a different number here. Again, you're going to do the same thing, right? You're going to take your 1 gram, you're going to move it over 3 spaces to become milligrams. So in Epi 1 to 1,000, there is 1 milligram of epinephrine in every milliliter of medication that you have, which is this vial right here, right? So think about it this way, right? You're going to draw up 0.3 milligrams, which means you're going to draw up 0.3 milliliters, okay? It's like a 1-for-1 ratio there. As opposed to Epi 1 in 10,000, you move the decimal point over to make a gram into milligrams, and then you divide by 10,000, right? So that means that you have 1 divided by 10. That means you just move your decimal point over, and it becomes 0.1 milligrams per milliliter. So now if you're comparing these two, 1 milliliter of Epi 1 to 1,000, let's just start over with that real quick. 1 milliliter of Epi 1 to 1,000 is the same amount of medication that's in this 10 milliliter vial, okay? It's just diluted with 10 mLs of saline. So, for example, if you happen to be on a call and you have perhaps a bad asthmatic, you can't find your Epi, right? It's in your protocol for bad asthmatics. You can't find your Epi 1 to 1,000. You can still give via IV 3 milliliters of 1 to 10,000 to accomplish the same amount of medication. Does that make sense?
Repeat that.
So where you're drawing up 0.3 milligrams here in the Epi 1 to 1,000, the same amount of medication is in 3 mLs of the Epi 1 to 10,000. So let me show you kind of a easy way to think of that. Right, so if you have 0.3 milligrams, right, which is the same as 0.3 milliliters. That's in the 1 ml vial, right? In your 10 ml vial, it's the same 1 milligram of medication in both vials, but it's diluted with 10 mLs here. So see how that extra 10? So to administer 0.3 milligrams of medication from the 10 ml vial, you're going to administer 3 mLs. Next time you're on an ambulance, look at the two different vials. Does that make sense? I think I've lost somebody. I've lost at least one person.
So Nicole, I'm looking at this also, obviously, the way you have it listed is so you have 1 gram and 1,000 milliliters, which is 1 liter. So we're not going to be getting a 1 liter bottle with an epi concentration in it. So obviously this is being reduced down to the actual medication size in the ampule.
Yes.
So that's, I mean, okay, that helps me understand that a little bit better.
So at the same time, so like if you look at the box, so every milliliter of this epi, the epi 1 to 1,000, 1 milliliter is 1 milligram. If you look down here, it even tells you on the box, every milliliter of the epi 1 to 10,000 is 0.1 milligrams. Okay, because it's diluted. There's more water in this one, but the same amount of medication. So if I wanted to give 0.3 milligrams of this, it's just 0.3 milliliters. If I wanted to give 0.3 milligrams of this, it's 3 milliliters. Does that make sense? Because this is 10.
So the 1 in 1,000, you draw it up to the 0.3, whatever. That sounds like I use the check and eject. It has like the 0.3. Just draw it up to that. But with this one, but that's for 0.3 milligrams.
0.3 milligrams, yes.
Yeah, but that's but the equivalent of that for the 1 in 10,000, you just draw up 3 milliliters instead.
Exactly. And it's the same amount of medication. It's just there's more water in one than the other. Make sense? Okay. Some formulas that you're going to need to know. The first one's your universal drip rate. Okay. This is all entirely dependent on what kind of administration set you're using. Okay. You have two. One of them is the macro drip. This is this one on the side. Makes a really big macro, right? Think about, really big macro drops. Okay. These come in 10, 15, or 20 GTTS, which is drops, per milliliter. Okay, so think about having like an eyedropper, and I said, okay, every 10 drops is 1 milliliter. That's what's going on here. And then you have your micro drip, which is ones you use for more accurate medication administration. It has this little metal needle point, so it makes a smaller drip. There's 60 drops in 1 milliliter for this one, okay? So when you are giving a medication that you want to give a very specific amount, the drip rate that you're going to use is the desired dose, how much you want to give the patient, right? Over the dose on hand, how much you have, right? How much medication is in the bag that you're hanging to drip. Then you're going to multiply it by your administration set. So if you're using a 60 drop set, it's going to be multiplied by 60. If you're using a macro drip, for sake of ease, we're going to say it's a 10 drop set, right? That's going to go here. To make your life easier, you can put that number over 1, just so everything lines up, and just some people have a hard time visualizing it. You don't need this 1, okay? If you're okay in terms of understanding where the fractions kind of come in. So, if you have a patient who weighs 154 pounds, and now he is hypotensive after you have resuscitated him, you are going to give him a dopamine drip. So if you're using a 60 drop set, and you want to give him 5 mics per kilo per minute, okay, how much are you going to give him? But you are putting 200 milligrams of dopamine in a 250 bag. It sounds like a lot, but I promise you it's not too much. Not too much. Not scary. So first thing that you're going to do is you are going to find out how many kilograms this patient is, right? Hold on, I'll do this in, I'll do it in the whiteboard so you guys are, it's kind of less congested. All right, so right, you have a 154-pound patient. You want to find out how many kilograms he is. If you have a total brain fart and aren't able to convert that over, really easy, right? You're having a rough day. You take your decimal, you move it over here. Take this decimal, you move it over here. Add a 0. Now we're going to divide, okay? So now you're working with the number 22. 22 go into 15? No. Does 22 go into 154? Yes. It goes in 7 times, okay? Now, I don't know, I did this when I was a kid just to kind of help myself, right? It says 4, 7 times 2 is 14, plus 1 is 154. Okay, now don't forget you still have a placeholder because your decimal is over here. 22, or 0 divided by 22, right? How many times does 22 go into 0? 0 times. So you have a 70 kilogram patient. You want to give your 70 kilo patient 5 mics per kilo per minute. So your desired dose, 5 times 0 is 0. 5 times 7 is 35. So you want to give him 350 micrograms per minute. Come on. There we go. So you're going to keep this number in your head, okay, as we find out what our dose on hand is. Right? So this is how much medication, dose on hand, how much medication we have mixed up. So the question tells us that we are putting 200 milligrams of dopamine in a 250 milliliter bag. Now we need to find out how many milligrams, we need to find out how many micrograms per milliliter exist in this formula, okay? Because dopamine is given here, we're looking for micrograms, right? So you need to make sure that all of your units match. So super easy, right? You're going to move that decimal point over 3 places. Thank you M, thank you G, here. So 200 plus 3 extra zeros is how many micrograms you have. And you're putting all of that into a 250 milliliter bag. Okay. Cancel out your extra zeros. And then you're going to divide. 25 goes into 20,000. Make sure you have all your zeros. Got a little cross-eyed right there. Okay. Think of quarters, okay? Especially this is going to help you here, and I'm going to show you something else in a little bit. Right? So 25 does not go into 20, but 25 does go into 200, right? How many?
8 times.
8 times, right? You have $2. That means you have 8 quarters. 200. 0. Again, we drop the 0. $800. Okay, so you have your dose on hand is equal to 800 mics per milliliter. 200 milligrams in 250 milliliters is a pretty standard dopamine dose that you're going to see on most test questions. It's a good reference point also. If you just memorize that 200 milligrams in 250 milliliters is 800 mics per milliliter, you can save yourself this whole math trip. Okay? Just a thought. Anyway, so now we know how much we have. So we want to give our patient, right, 350 mics per minute. And we have our dose on hand is 800 mics per milliliter. Okay, and we know that our administration set is a 60 drop set. I'm going to put this over 1 just so everyone kind of can see that, right? So you can work here and make this a little simpler first if you wanted to, right? You do this math. Or you can multiply across, so that would be 350 times 60 divided by 800 if you wanted to. Whatever is your preferred way, okay? It doesn't really matter. But you can simplify it before you multiply over, right? So 350, get rid of your zeros. So you can do 35, I'll put 60 up here, times 60. Right, so 5 times 0 is 0, 5 times 6 is 330, so that's 300. Placeholder 0. 3 times 0 is 0. 3 times 16 is 18. 0, 0.
2100.
Thank you. All right, so you have 2100. That's a terrible 0 divided by 80. Again, you can cancel out your zeros. 8 into 210. Okay, 8 goes into 21 twice. Right, 16. It goes into 50.
8 times. Sorry. 6 times.
6 times, there we go.
I can't do
6
math.
times.
It's alright,
6
no one can
times.
do math. It's too early in the morning. So, you have this remainder here, okay? You can't leave this. This is not adequate, right? So if you're doing long division, you put in your zero, your decimal place, and then you can extend this out forever and ever. Okay, so you put a 0 here, you bring your decimal point there, then you bring it up here as well, because you don't want to make it too big. Bring down your 0, goes in twice, and add another 0. It goes into 40. Let me hear how good everybody's math skills are today.
5.
But Jonathan.
Yeah.
Yeah. 40 minus
5.
40 equals 0. Okay. So this is your drip rate. Okay. So you are going to give your patient 26.25, 26 and a quarter drops per minute. Okay. That makes sense.
Okay.
Either everyone's having a panic attack, everyone's fallen asleep, or everyone's good and
It's
got
like
it.
it's when you go over this, it makes sense, but then like if you told me to do this by myself, I'll be like, I totally get lost again.
It's honestly it's just practice and repetition. So we're going to go back to this here real quick. Okay. So we talked about, and this is another like ratio thing that we're going to talk about. So if I come over and I say, okay, that's great, cool. I don't carry 200 milligrams of dopamine. I carry 400 milligrams.
Wouldn't that just be 400 mics per milliliter?
Hold on. It depends on what you're mixing it in. You're not going to, it's going to be more concentrated, but it depends on what you're mixing it in. So you say, okay, listen, I have a 400 milligram vial of dopamine and I don't like to waste it. I'm going to use the whole thing. To make the same exact concentration, what size bag, saline bag, should you mix it in?
500.
Perfect. Right? Because are these two equivalent? Are these two fractions the same?
Yeah, those are the same.
Okay. So right, if you simplify this, you can make this, which means that your answer is still 800 mics. Now, if I say, oh shit, I don't have a 500 milliliter bag with me today, I only have a 200, move yourself, I only have a 250 milliliter bag. No longer equivalent, right? Is this more concentrated or less concentrated than this one?
More.
Oh,
More. By how much?
Half or double.
Double, right? So if I was to move this all the way out, right? So if I was to say, here's right here, I'll give you the 1, 2, 3, right? So 1, 2, 3 divided by 250. Boom, boom. $25 goes into 40.
Once.
There you go, once. $25 goes into 150.
6.
Right. See how that changes your formula? So now if we were to go back to here, and I was to change this to 16, right?
She's double the drip rate.
Am I doubling it or halving it?
You would have it. Sorry.
There you go. There you go.
You'd
So
have it. Sorry.
let me put it out there for everybody, right? So this remains the same, right? So you can still cancel out your zeros. So 35 times 60. That's bad, right? So you got 2100 over 160. Cancel out your zeros again. 16 goes into 210. And once. $16 into 50.
3.
For those of you who are.
It's 48.
Yeah. Decimal. 0. 16 goes into 1. And another 0. 16 into 40.
2.
Trying to squeeze everybody in there. 32. 8. 16 into 80.
5.
There you go. Okay. So you see how that changes? You don't have, if you make your concentration of your medication stronger, your drip rate's going to be smaller. Okay, so if you make it twice as concentrated, you're going to make the drip half as much. Now, this is sort of the same. So now, well, let me just put it on a brand new page for you. Things you should kind of memorize because it's just useful. That's a nice color.
Nicole, so is this going to be on the next test?
The next module exam,
Yeah.
we will go over more. I promise. We will do this.
No, but like, would we have a different time limit since we have to like do math and stuff?
Yes.
Okay.
Wait, so this might sound like a silly question,
Go ahead.
but being more concentrated would meaning there's more, let's just say, of the medication than there is saline, correct? Is that what we're saying?
Yes.
Or that's
Yes.
what we're referencing?
There's more there's more medication in each drip.
Okay.
And in that case, we just halved it because it was the more medication, but in the same amount of saline or solution.
Yes.
Oh, okay, that makes more sense.
If it was a different amount, then we'd have to do the whole thing all over again because it would be different.
Here's your pro tip for the day. Okay, and this is, we just talked about this. These are your dopamine kind of standard doses that you're going to end up seeing on test questions and such. Okay, sorry for the atrocious handwriting. Right? And that right there, that's the quote-unquote hardest math that you're going to do. Honestly, the hardest part is remembering long division in your multiplication tables. Okay? You guys are going to have this, no problem. So after... Sorry, go ahead.
No, I feel like people might hate me after I say this. But for like, because, all right, do you think for some of our homework we could do like, be assigned like kind of equations like that to work on?
If you look at your workbook, there's a bunch of math questions in there for you.
Oh, okay. Okay, good.
Trust me, and if you want, we can do those workbook questions the next time, and we can go over them. I'll even do them with you guys so that we just have practice and you see it. I'm totally okay with that. But look at it and try it on your own first, and then if you have questions, we'll go from there. How's that sound?
Sounds good.
Okay, cool.
So Nicole, I think what I'm getting from this is the more we can become familiar with the medication and memorize the standard dosage, the protocol dosage, that the real difficulty is when we have to improvise, like you're doing now.
Yeah. Basically, filling the patient's weight is going to be, I think, the hardest part.
Okay.
All right. So now that you've kind of like had a small, freak out moment about that math, and we've gotten over that little hump, volume drip rate is super easy. So if there's a specific amount of medication that you need to give to a patient, what you're going to do, right, it's going to be the volume that you're giving over the amount of time, times the administration set. So this is when you're giving somebody like magnesium, right? Or you're giving them 150 milligrams of amiodarone for VTAC with a pulse, okay? You're setting it up in a pre-mixed solution, but you're going to end up giving them the whole bag, okay? But you don't want to give it to them too fast where you like tank their blood pressure or something like that. So you're going to give it to them over a certain amount of time. And that time is going to be in minutes. So if you have a patient who requires 150 milligrams of amiodarone, we're going to go back to here real quick, 150 milligrams of amiodarone, and you are going to put it in a 100 ml bag, and you are going to give it how long? Over 10 minutes. Okay, this is your information. The biggest part of that people seem to have a problem with is actually picking out what the important information is. So you need to understand when a question is worded, and this is also based on what medication you're giving, what formula you're going to use. You are never going to use this formula for dopamine, okay? You are never going to use the dopamine formula for amiodarone. So making sure you know what medications use what formulas will kind of eliminate a lot of that problem. But you also need to know that if someone starts saying you're going to give it over this amount of time, that, you know, and you're mixing it into a significant amount of fluid, that you're going to be using the volume over time, right? So volume over time times your administration set, which is, I believe it was 60, over 1 for a nice placeholder, equals. So the volume, does it matter how many milligrams we're giving? Not really, right? I could tell you, this guy looks like he might die. Let's give him 300 milligrams, right? You're still putting it in 100 milliliters. Okay, so your volume doesn't change. Your volume should always be milliliters, okay? And your time is going to always be minutes. So you're going to give your patient 100 milliliters over 10 minutes. And even if you look at the question, let's go back to the question real quick. You're going to give a patient 100 milliliters over 10 minutes, right? So that kind of gives you an, right? It's over. You're dividing it times 60. Cancel out your zeros. 10 times 60. Okay, that's 600 drops a minute. Now, if I was to say, okay, that's a lot of drops to count, I'm not really feeling that, I'm going to use a macro drip. And that macro drip is going to be 10 drops per milliliter. Pretty simple, right? If I decided, no worries, friends, I have a 15 drop set. Really liking this 15 drop set today, right? Right? Now think about it, right? 15 drops, there's 15 drops in a milliliter. So you only need 150 drops a minute to give the same amount of medication. Make sense? Everyone's died. Come back. Oh, you're breathing. That's exciting.
What I'm confused about here is if the drop set only gives 60 drops a minute, that's the maximum, right? It can do?
No.
The mechanics of it?
No, mechanic. So if you open that wide up, it's going to be significantly, it's 60, the drop set is 60 drops in a milliliter.
Okay.
Yeah.
That's how it's, okay.
All right.
Yeah.
Okay.
So you're calculating for how many of this size drop over a minute.
Okay.
That's why that.
So what's the drip rate then for a 60 drop per milliliter bag if I open it wide open? Do we know that or no?
It actually, if you look at a drop set, it will tell you on it.
Okay.
I don't know that information right off the top of my head.
Okay. So but that's also important to know when you're selecting your, if you know what your drip rate is, you want to know what drop set you're going to use.
Yes. So for the most part, if you're administering a medication, you're going to use a 60 drop set because you want to be able to calculate, accurately. But if you take a macro drop set and you put it into a 100 milliliter bag, it takes about 10 minutes to administer that entire 100 milliliters wide open.
So also, if I remember correctly, and this is going in the Wayback Machine to the 80s, if I wanted to figure out how many drips per minute, I would just look at the drip dropping. Aside from the milliliters, the 60 drops per milliliter, if I want to know how many drops per minute, I would simply look at the window or the cylinder and count.
Yes.
Roughly count.
Yes. So you can continue. So if you wanted to say, okay, well, I need to now set my drip up, right? So I know I need 150 drops a minute. So there's 60 seconds, right?
Right. So it's going to be 2.1 something per second.
Exactly.
All right.
So, going into 50, it's about 3.
So when we're in the midst of a cardiac arrest or a big trauma call, we're not doing math on a calculator or on a worksheet. These are shortcuts we can learn or implement, obviously.
Yeah. So, well, I will say for the most part, the medications that you're giving for traumatic issues, generally you're not doing much medication, right? Trauma's BLS.
Right.
So the most thing you might be doing is like being really nice and be like, here's some fentanyl. Right? Stop being in pain. But if you are looking at a patient in cardiac arrest, for the most part, you're bolusing your medications. If you get them back and you need to give dopamine, then you're, going to your dopamine. A lot of times and you're not going to do this in class, and even in, you're going to calculate how much you're giving them. But a lot of times what they do is they titrate to effect, because the protocol actually gives you a range that you're going to use. So it's anywhere from 2 to 10 or, 5 to 20 mics per kilo per minute. So you might calculate it out and say, okay, I need to give this patient, 3 drops a minute or 3 drops a second, and it's not having the desired effect. You can double that, right? So say 5 mics per kilo per minute was 3 drops a second. Okay, I want 10 mics per kilo per second. You double that, right? So it ends up being 6 drops a second. So you're actually then going to be controlling that little thumb dial. Yes.
I guess they still use that little thumb dial and looking at the patient.
Yeah. Well, you're monitoring the blood pressure.
Right. Vital signs. Yes.
Absolutely. Yes.
Okay.
But a big thing that you also need to make sure that you do is to make sure that you label your medications. I cannot tell you how many times, even with a labeled medication, you walk into a hospital and they go, oh, his blood pressure is not that great. And they decide to turn up the vial, the little roller ball, on the dopamine. And then 2 minutes later, the patient's blood pressure is like 300 over 120. And they're like, what happened? And you're like, well, you turned the dopamine all the way up. So make sure that it's labeled very clearly, because if the hospital screws up, they're going to try to dump it back on you. So just a word of caution. So let's see what else we got left on this.
What's the rate of KVO?
It is about 3 to 4 drops a second. Or a minute, sorry. It's slow.
Thank you.
No problem. All right, so we did that. Okay.
So I presume when we get into clinical or laboratory rather settings and we're working on setting up IVs, this will be part of the practical clinical or laboratory setting experience. Okay.
Yes, it will.
Can't get in there soon enough.
Yeah, I know. It'll come, I promise. So, just some standard solutions that we use, right? So we talked about all your dopamine here. Other solutions that you're going to potentially encounter in so much as in the lab, or because epinephrine is really like, we will test you on how to set up an epinephrine drip, because it's a national registry item. Norepinephrine is now in protocol, so you need to know how to mix this. but your standard mix for norepi is 4 milligrams in 250 milliliters, and that calculates out to 16 mics per milliliter. Okay, and we'll do that again at another time. We'll go through that maybe next week to kind of just practice math. Okay, but just for now, just keep this in the back of your head. Another one that's not here is lidocaine. Sorry, move forward. But that can be changed depending on how the concentration of your lidocaine. So we'll talk about that again at another time. Your medications that you traditionally use as volume, right? We talked about this already. So it's amiodarone. It's 150 milligrams in either 50 to 100 milliliters of D5W. And then you have 2 different types of magnesium drips that you can give. One of them is for torsades, or as we said in POC 23, I believe, torsade de poids, the most French of dysrhythmias, is 2 grams in 10 milliliters of normal saline. Okay, versus when you're giving it for preeclampsia or for asthma, it's going to be 2 grams in 100 milliliters. Okay, so if you kind of think in your head what's more serious, a fatal dysrhythmia where you want to make sure you're giving that medication rapidly versus, an asthma attack where you need to give it gradually so you don't, cause them all sorts of issues. Okay, that's where the change happens. So the 2 grams and 10 mLs is also, I think they can, as a medical control option, give this to you if you have a patient who's gone from preeclampsia into eclampsia, right? Just kind of judging based on the severity of the call type is going to kind of direct you here as well. All right. How are we all feeling?
I'm sorry, what?
I'm sorry, I just came back to reality real quick.
I feel pretty good, but what I guess, again, what the disconnect might be for some of us is how all this is going to happen in the bus. And I think the reassurance that
Agree.
obviously the practice on the formulas and in the labs, there'll be obviously some theoretical situations on the testing, but this will all become second nature from what I've seen, obviously.
And I want to say, so dopamine is supposed to be set up on, they've changed this a few years ago, that it now needs to be on a dial-a-flow. And dial-a-flows are actually calculated in drips per hour. So it adds another fun step to the calculations that we're not going to make you do.
What's a dial-a-flow?
It's this really fun piece that you put in between the medication and the patient, and it literally is a dial. And on the dial, it gives you different drip rates. So you open.
Is that like an automatic device then, or still manual?
It's still manual. It's
okay.
It's cute. It's like a throwback. So basically, you open your roller ball for your main line all the way up, and then you put this piece in between, and then you set it. So it'll be like, you want to give this patient 10 milliliters an hour, or you want to give this patient 100 milliliters an hour, and you can just literally roll it until the arrow lines up with the medication amount that you want to, or the fluid amount that you want to give. That's what it's supposed to come on. I don't think that anyone has actually followed that protocol appropriately, but vasopressors are supposed to be very carefully controlled via a pump or something, but no 911 system's going to buy a pump.
Okay.
I just want to add something.
Yeah. Go ahead.
They use that a lot in transport. When I work with the medic, they have exactly what you're talking about. It's like white and then blue, and then it has the dial on it.
Yep.
Yeah, my medics use it all the time.
Yeah, well, transport, you have a significantly longer transport time, so you need to make sure that this is on point. They really should have the little Alaris pumps, which are also super fun because they just beep at you the entire time. You're like, what's beeping? Why are you beeping? Yeah. And you're like, what is making that noise? Air in line. You're like, ah! Yeah, so they are very commonly used, and they're very useful if it's going to be an extended transport. The thing is, in the city, it's like, how far are we from the hospital? 10 minutes, but I can make it 7? It's a lot of titrate to effect. And then the math is done later. Let's just give you an idea of what reality is. How much did we give that patient? It was definitely 5 mics per kilo per minute. Definitely. right? So you're kind of just making sure the patient's alive.
So,
yeah.
Nicole, back to the test question with the math without invoking the Americans with Disabilities Act for myself. I mean, the math thing, I love math when I can grasp it, but I think like everybody else, I'm going to want as much time as possible on the math.
You'll have plenty of time.
Yeah. Okay, great.
And usually I want to say the state gives you maximum around 5 questions of like math questions. Like the majority of times you'll maybe see like 1 or 2 dopamine questions, but you'll like most of the time you'll see like like you have a vial with this much medication in it. How many milliliters are you going to give for this dose? So it's a lot of just simple cross multiplication that you're going to be using the majority of the time.
And I'm sorry to interrupt you, but in the assignment modules where there's it doesn't reference a chapter, but it has a P or something. What is that? What's going?
Is that
in
PowerPoint?
in the syllabus?
The syllabus is a piece of PowerPoint. It's not it's a self-made PowerPoint.
Okay.
Because like we're going to do the New York City drug formulary. So like the textbook doesn't have that because it's specific to our region.
Okay.
So let's see. I think we might have covered, this is all right, we're going to power through the 2 other chapters that we're supposed to do today. It's principles of pharmacology and the medication administration. I think medication administration we've pretty much covered, but I'll just go through the slides with you one more time just in case I've missed anything. So pharmacology, and this is again like sort of like when on the test pathophysiology was a important definition to remember, is the scientific study of how various substances interact with or alter the function of living organisms. So the FDA was kind of instituted in the 1930s, and then the Controlled Substances Act was brought to you by the 70s after the 60s haze kind of cleared up and people remembered that they should probably function appropriately. So just, these are the main things that kind of you deal with in terms of being a person who carries medications. Controlled substances are scheduled. So if you are a Schedule 5, it's considered there's a medical use for it, and there's a low potential for abuse of the medications. If you're a Schedule 1, it's a high abuse potential, but a very minimal medical use, supposedly. There's a lot of research going on right now for LSD, for PTSD, marijuana for pain management and stuff like that. So it's just the fact that we haven't accepted the medical uses into popular domain yet. And then this is where we kind of usually hang out, is in the schedules 2 to 4. So when we're dealing with seizure patients, we're here with your Ativan and Valium. Midazolam hangs out here also. When you are Dr. House, you have your Vicodins. Ketamine is a little considered a higher schedule because there's a more abuse potential. And then you have your high abuse potential is fentanyl, Ritalin, which is, just prescription meth, and cocaine. Cocaine is actually really interesting as a medication because they originally used it as a dental anesthetic. It's also still used today to help reduce nosebleeds. So if you wanted to go to the hospital with a severe nosebleed and it's not getting better, they'll actually take like a little bit of cocaine and just topically administer it, because it will constrict your blood vessels. That's why people who have bad cocaine addictions lose the septum, because they literally will restrict all of the blood flow to the nasal septum, and that's why they start basically putting holes through their nose. It's because of the necrosis that happens due to lack of blood flow. Different sources for medications, right? You have your plant, animal, bacteria, microorganisms. A lot of antibiotics kind of come from this area, or the original antibiotics came from here, and minerals. They come in different forms that depends on really how they will be administered, right? So if you're going to give somebody albuterol, you're not going to have them take it orally. It's going to be inhaled, right? Because it works best when it's on the membranes of the respiratory system. So it kind of ties into its own action. Different names that you need to know for a medication, right? So there's the chemical name, which no one really knows because it's just long. It's got commas and hyphens involved. The generic name, right? So if you're taking a blood pressure medication and it's, not the brand name, which is maybe metoprolol, Lopressor, the generic name is metoprolol. And then you have the trade name, which kind of hangs out there as well. A lot of medications will have what they call the tall man lettering. You'll probably see this a lot on patient discharge information. It's when you have very similar sounding medications that they will put certain aspects of it in capitals. This is actually supposed to be dobutamine, because you don't want to be giving somebody dobutamine when they really need dopamine, right? Or you don't want to give somebody dimenhydrinate when they need diphenhydramine. Okay, so they capitalize it to draw attention to it, so there's fewer medication errors that are being made. If you look at the little insert inside any medication that you get, usually from the pharmacy, which is the best information you're ever going to get on a medication, these are all the things that are part of the medication profile. Okay, so obviously whatever names it goes by, the chemical, the trade, the generic name, if it has a generic, what kind of drug medication, what category it falls into, what it's being used for, and again, what you should be is contraindicated for, right? So glaucoma is a very popular one. It's a contraindication for a lot of medications. It also tells you how the medication works, okay, like what it does. So beta blocker, for example, binds with beta adrenergic receptors in various parts of the body and prevents the sympathetic nervous system from stimulating them, right? So that would be its pharmacodynamics. Pregnancy risk factors, they keep changing this. It used to be A, B, C, X. Now they have different lettering or numbering for it. The different forms, right? So some medications are available only as oral tablets. Some of them are oral, and some of them are also like IV suspensions that are available. Traditional dosages that you would see, right? So everybody kind of knows, Benadryl is 25 milligrams, right, in a tablet, or baby aspirin is in 81 milligrams, right? But you can still get a 325 milligram aspirin. How it should be administered, right? Is it going to be IV, oral, rectal? What you should look for in terms of the considerations, right? Rash or other issues like that would be here if the medication has a potential to cause cardiac dysrhythmias, like maybe hydrochloroquine or something like that. This would be here. One of the big problems that we have in the United States is that people are on so many different medications. It's called polypharmacy, that sometimes one doctor will prescribe one medication that doesn't interact well with another medication, right? So you might have an issue with these two medications, and usually the pharmacist, if you go to the same pharmacy, they pick up on that and they say, oh, you can't take this, or you can't take it at the same time as this other drug, right? Because then you'll be, unconscious, or you'll vomit or something like that. Adverse effects, right? I think hypersensitivity is the most common, right? That's the first one that's always labeled. It might be an allergic reaction. And then pharmacokinetics, right? How the medication moves through the body and is ultimately eliminated. A lot of medications are eliminated from the body through the kidneys. There are some medications that are actually eliminated through the skin, like through your pores and like through sweat. And most medications that you take orally go through what's called first pass. Hold on, I brain farted a little bit. They pass through the liver first, and they are metabolized. First pass metabolism, that's the word I'm looking for. The first pass metabolism, where they are broken down by the liver. So if you're taking a medication orally, it's not often in its useful form, right? So the drug companies make sure that you are getting a medication that's functional. So they will accommodate for the fact that everything goes through your liver and your liver will metabolize it. So the medication that you're initially taking isn't going to work until the liver breaks it down. And then the byproducts of that medication are actually what works on the system. That's why a lot of oral medications take about 20 minutes to work. Some medications like aspirin are very acidic, and acid likes acid. So when it's absorbed in the stomach, it's instantly absorbed into the bloodstream. Okay, so if you have a very basic medication, it's not going to work as effectively as an acidic medication, just based on the environment of the stomach.
Quick refresher question.
Sure.
As far as acidic and alkalytic, which one is the more hydrogen? Oh, that's a silly question. Alkalytic, right?
No.
Because it's no, the other way around.
Yeah.
All right, never mind.
Acids have more hydrogen. Bases have more OH.
Alcohol.
Or no, it's OH negative. That's not an alcohol.
Okay.
It's one of the buffers.
Gotcha.
Bicarb or something. That's not bicarb. Okay. Different areas, different sources where you can get medication information. Okay. As I said, the medication inserts that you find are the most common. The United States Pharmacopoeia, I really just wanted to say the word pharmacopoeia for you guys, is also very helpful. I think they have an online way that you can, an online reference. A lot of medications are very temperature sensitive. Like, for example, cardizem, right, is one of the cardiac medications that we carry on the ambulance. It needs to be refrigerated. So that medication, we can't necessarily refrigerate on an ambulance. So once we take it out of refrigeration, it's only good for 30 days. Okay, so it kind of moves up because it's not as effective. It loses a lot of its power. Controlled substances need a controlled substances policy. So either it's a one-to-one handoff, there's a locker, some sort that the medications can be put into that is secure and has a medication or narcotics log, right? That's all very important things. We talked about both of these things. These are very important concepts for you to understand, okay? Pharmacodynamics is how the medication dynamically changes the body's processes, right? While pharmacokinetics is how the medication is kinetically moving through the body, okay, right? So it starts in your mouth and goes through your liver and then ends up in your kidneys and ends up in the target organs, all of those things, okay? So just make sure you remember the difference between the two because it's very commonly confused. I feel like I just skipped one by accident. Different types of medications, the classifications. So we have agonists, which come in and attach to the target tissue and the target receptor sites and will prompt the normal response. So epinephrine, for example, is an agonist. You give a patient a epinephrine. It stimulates the sympathetic nervous system receptors to increase your heart rate, to dilate your eyes, and do all of those things, okay? That's what the normal reaction of the body is to epinephrine. As opposed to a medication that is an antagonist, right? It fights against the body's normal response. So things like beta blockers, okay? Where they come in, and if you look at this picture here on the side, the furthest to the right, they come in and they block the receptors, okay? So if this is your normal body's epinephrine response, right? Because, oh my God, something scary. If you are taking a beta blocker, it won't be able to bind to the sympathetic nervous system response, and your fight or flight response is going to be dulled. The heart rate's not going to get as high. Your pupils might not dilate as much as expected. That normal fight or flight response is going to be dulled a little bit. There are different aspects of how medications work. The affinity, right? So the ability of medication to bind with the receptor site. This is why Narcan works. Narcan has a higher affinity for your mu narcotic receptors than narcotics do, which is why you give Narcan, the patient wakes up, then Narcan has a shorter half-life than a narcotic, so 20 minutes later, if the Narcan is bounced off of the receptor because it's kind of gone through its half-life, the narcotics can start working again. Threshold level is how much you need to actually change the way that the body's functioning, right? So you might be taking, 10 milligrams of aspirin, but the minimum to make platelet aggregation, less, or to make platelets aggregate less effectively is 81. Okay, so again, same thing with potency. Also threshold level. So you ever have a patient who has a seizure, right? And they bring them in and they give them what's called a loading dose, like Keppra or something like that. That bumps up the body's threshold level. Okay. Efficacy, how efficient the medication is. It's like some medications are more potent than or more efficient than others. So that's why one, atenolol might be a stronger beta blocker than metoprolol, right? Because it has a higher efficacy. The dose response curve is sort of like this distribution curve. So like you have nothing in the system, then you have a lot of medication, and then it kind of goes through metabolism and there's less in your system. This is why there's some medications that you have to take multiple times a day, right? So if you have that extended release medication, you only have to say maybe take it every 12 hours because the dose response curve, it hits that threshold level, it stops doing things. They also have partial agonists, which are also sometimes called agonist-antagonists. So they will bond to the receptor site but not create as much activity. Antagonists come in two flavors. The competitive type, which can be bumped off of the cells, and the non-competitive antagonists. So the kind of weird part about non-competitive antagonists is when they permanently bind with the receptor sites. So their mechanism of action is a little bit longer because now you need to wait for your body to create brand new receptor sites. This is why barbiturates were so troublesome, because they were non-competitive. So the body would then create like an uptick in terms of creating new receptor sites, so they became less effective. So you would increase the dose, and it was just like a cyclical issue for barbiturates. Other things that we might see that we don't really deal with that much in the emergency setting, like antimicrobials, right? Things that are antibiotics, chelating agents, which is usually used for heavy metal poisonings, diuretics. We do deal with diuretics, but more in a chronic setting. I do believe they took Lasix out of the protocols in most places just because of the longer onset for the medication to work. So it's not particularly useful in the emergency setting here anyway. A lot of different things will affect how medications respond, okay? Obviously the dose, right? If you take a very high dose of a medication, for example, I don't know, morphine, you're going to have much more, side effects, I'll call them side effects, than if you took the normal regular dose. Patient age, right? We talked about how a lot of medications do first pass metabolism through the liver. If you're older and your liver isn't functioning as well as it should, you won't necessarily get the same benefit from a medication. The same token, if your kidneys aren't functioning very well, you will have a higher buildup of the medication in your system because they can't eliminate it from your body as easily as if they were healthy. Genetics is kind of cool. So Plavix, there's actually a genetic mutation where Plavix doesn't do anything for certain people. Because it actually, the body just kind of goes, that's cute, and metabolizes it right away, so it doesn't ever affect blood clotting. And there's a lot of people who have it that they're just kind of finding out about, like especially people who are on Plavix for, status post stents or whatever, and still having like bad heart attacks. They're like, we should probably check to see if you have this. The environment is very influential as well. Go ahead.
So Plavix is a blood thinner, correct?
Correct.
is it also used for arthrosclerosis?
Yes.
Or is it just like a combo with something else for it?
So Plavix is usually used after a like a MI. So you
So my Nona, my grandmother,
Mhm.
has like, you know, has all the fun stuff, hypertension, everything like that. So she's like on Ecotrin, she's on
Okay.
Plavix,
Okay.
and she's on some other stuff, but she also has severe arthrosclerosis
Okay.
throughout in her external in her carotids,
Yes.
and part of her brain. So we saw the fancy which was stroke and MI
Doctor.
brain aneurysm guy
Uh-huh.
at Good Sam, right?
Yeah.
Super nice guy, but he was like, oh yeah, like it's whatever, but as long as you stay on those combi drugs, you should be fine. So he's not even worried about it. I
Yes.
then later found out that you can go in and like clean it out, but that's besides the point. So the point is, she had like 7 stents.
Okay.
So if it's not working as well, would Plavix? Does Plavix have any effect on the buildup of arthrosclerosis? Like obviously it has some effect because it's thinning out the blood and it's there to reduce the amount of plaque buildup by
It's
not clotting or creating a clot.
yeah, so it's more that it's preventing clotting and not really doing much in terms of a plaque buildup.
Okay.
Yeah. Plaque buildup is like a
More
combination of inflammation and high cholesterol.
Gotcha.
So
I don't know what hyperlipidemia medication she's on.
she's most likely on a statin.
Okay.
That's the kind of the run of the mill. Everyone's on a statin kind of vibe because it does have protective, anti-inflammatory protections as well, which is why they're so popular. But yeah, the Plavix is probably they're using as a primary way to just protect her from clotting episodes.
Gotcha.
Yeah.
So yeah, should we believe she had a TIA a while back, and when by the time she got to the hospital, because I had to bring her. By the time she got to the hospital, everything resolved, and they said nothing was wrong. They just said it was related to the arthrosclerosis. So assuming it was probably just oxygen deprivation or something, but she was still not. Like I talked to her on the phone, and she was completely out of it. She had no idea what was going on.
Yeah.
So yeah.
Yeah, that sounds like a TIA. So.
But everything resolved, and there was no signs or symptoms.
Well, yeah,
by
no,
that
well, we'll do this in
Exactly,
neuro.
that's the point of a TIA. Yeah,
that's
no,
literally
I know.
the textbook definition of a TIA.
Yeah.
So, but the problem with the TIA is that it is indicative of a larger neurological incident in the future. So.
No, of course.
Yeah.
And she had a stroke in the past. She
Oof.
she had a vascular attack back in 2010.
Okay.
This was just this year that she had the TIA. I was at work, and my mom was like, "Oh, some sounds up," so I had to leave work and go and coax her to going to the hospital because she has like this terrible fear that she's gonna die there, which is understandable. She's 90.
Yeah.
But yeah. So I don't know, like, how would you know if Plavix or any of those other medications aren't working?
So Plavix, they actually do have a genetic test for. They can run it's during the traditional blood work. I would recommend if that they potentially check her because there's a lot of other novel drugs, sort of like Brilinta, that they could put her on in lieu of, to make sure that it's doing what it's supposed to do.
Gotcha. And I apologize for the brain fart when it came to mechanisms and drugs and
no problem.
I had a little moment.
No worries.
All right, thank you.
Yep. So yeah, so there's a lot of different things that can affect how the medication responds in the body. Ultimately, what we really want is the therapeutic action of medication. We want the patient to, if you're on a medication, you're on it for a reason. So like Plavix, you're on it so you don't have a stroke. If it's not thinning your blood effectively, then you're not achieving therapeutic results, and different medications should be tried. Other adverse untoward effects, Stevens-Johnson syndrome happens a lot. It's like an autoimmune stimulated created issue. Anaphylaxis, right? Patient or just regular old allergic reactions, medication sensitivities. There's a lot of different things. So like, for example, Brilinta, we were just talking about very briefly, has a very well-known side effect of causing shortness of breath. Is it because of the cardiac event that you just had, or is it because of the Brilinta? You know, sometimes it needs a trial situation for you to find out if it is or isn't creating, issues. Cumulative action. This happens very commonly with like seizure medications or Coumadin. Okay, so you need to make sure that Coumadin is very narrow therapeutic index, so that you need to make sure that the medication is not too much, because then you might end up with a cumulative action where it's creating the INR and the blood's really, really, really thin, right? Where you're just popping aneurysms. Idiosyncratic, right? Sometimes it's just like when you take a medication, it's supposed to do one thing and it does something entirely different from what it's anticipated to do. Synergistic, right? It's like a 1 plus 1 equals 10. So it's like the impact of the medication is way more enthusiastic than anticipated. And summative, where it's like 1 plus 1 equals 2, right? So we give one medication in combination with another medication to achieve the response we're looking for. They do that a lot with blood pressure medications. If you have a patient who's only on like one blood pressure medication, they are not a very serious high blood pressure patient. When they start, usually it takes 2 to 3 medications to actively control high blood pressure. So you'll see people who are on like an ACE inhibitor and a beta blocker and a diuretic, right? They're looking for that summative action of the medications to get the patient into a place where their blood pressure is not insane. So I said therapeutic index a little while ago regarding Coumadin. So the therapeutic index is the space in between the effective dose and the toxic dose. Okay, which sounds ridiculous. So what they do is when they're testing drugs, they find out what the dose is for 50%, the effective dose for 50% of the population. That's here. And then they also find out what the toxic dose is for 50% of the population. And they find, like, then they calculate the therapeutic index, right? So they want to have your dosage in this sexy safe window. Then that's the problem with things like Coumadin, is a very narrow therapeutic index, right? So imagine this space was like the size of this arrowhead, right? So the safe dose, the therapeutic dose of Coumadin is very close to its toxic dose, right? So when medications have a very broad therapeutic index, they're considered a little bit safer. You can and will build up tolerances to medications. And this is why some people, especially like high blood pressure medication patients and patients who are on like Lasix or something, the body will downregulate the number of receptors. So if you're taking a beta blocker, for example, your body will be like, I don't like this response, and it'll start reducing the number of receptors available so that it's not as potent of a response. Tachyphylaxis is kind of one of those fun things that can happen every once in a while, where repeated short firing of medications can cause can create tolerance to the medication, and it just won't work at all. And then you have cross tolerance, where you have medications from like similar classes can cause tolerance. So if you have a patient who's taking Ativan for seizures, and they're also taking Ambien to help them sleep, those can create a cross tolerance where neither of them work very well, and the patient might end up having like breakthrough seizures. Abuse and dependence is kind of two different but similar issues that we kind of been dealing with a little bit. For example, I want to say a good majority of EMS abuse energy drinks, right? We don't use them for in a good and effective way. We just drink them and we're awake all the time. Most of the time, stimulants and depressants are the two that are most prone, right? Alcohol is the same thing. Dependence is when it's like a actual emotional and behavioral need for the medication or the medication or stimulant depressant in order to operate, right? And you see this very commonly with alcohol, right? People who they go home and they drink alcohol, they have a beer every night so that they can unwind, or a glass of wine every night so they can unwind. That's moving into this dependence region, right? Because if they go home and don't have their glass of wine, it throws off their whole schedule or something to that effect. Habituation, right? Your body starts to kind of create an abnormal tolerance. Again, we see this with like a lot of the alcoholics that we pick up, right? They drank 2 bottles of Georgie for breakfast and they're still somehow able to stand, right? They do the breathalyzer test and it's not as high as you would expect, or it is as high as you expect, but there's somehow still ANO3. That's habituation. Your body will downregulate the receptors and such so that you can still function because you're doing enough abuse to yourself. We talked about this already, right? So the onset of most oral medications is around 20 minutes because it needs to do that first pass metabolism through the liver in order to be absorbed into the body and to the target tissues. There's a number of different things that are going to affect how well your pharmacokinetics works, right? So if you have a patient who's in cardiac arrest and you're giving them epi and you're giving them calcium and you're giving them bicarb and they're not getting any better, that's probably a distribution problem, right? The blood is not moving around the body effectively. You should probably do CPR more enthusiastically because it's not getting to the target tissues and doing what it needs to do. If you have a patient who is experiencing like an overdose, like a beta blocker or something, maybe they have a kidney failure and that beta blocker is building up in their system because they're taking it as they're supposed to, but they can't get it out of their body. Each medication has its own unique duration of effect, right? But it will reach a peak at one point. So usually it's, within the first few hours of taking the medication, and then, the effects of it will wear off.
Another
Sure,
quick question.
go ahead.
So, as you were just saying, like somebody who takes their beta blockers and everything like that normally, say you have a patient that's in cardiac arrest and you go to push something that is similar in makeup to what they normally are prescribed, will they not respond as efficiently due to the fact that their body's probably already somewhat tolerant to its effects?
Yes, potentially. So like that's so I think a better just example would be if you have a patient who's an AFib and they take amiodarone normally. If you give them more amiodarone, it's probably not going to do anything because their body has built up a tolerance. But if you give them cardizem to control the AFib, you might have a better effect on the heart because it's new and the body's not like prepared to attack against it, kind of thing.
Gotcha.
Okay. So we talked about the first pass metabolism a number of times already, right? So many medication that you take orally is not as bioavailable as an IV medication, right? So if you do give anything like through the IV, it's going to be 100% available right away, right? This is why the onset of IV medications is so quick. Other medications, so anything that's quote unquote enteric coated, right? That's it's covered so it makes it through the stomach and is absorbed in the intestines. Doesn't go through as significant of a first pass metabolism as something that's absorbed in the stomach, just based on where the portal vein is. Big star on this one. Oral medications can only be administered if the patient is awake and able to swallow, or has OGNG. But for the most part, we don't deal with tubes, so they need to be awake and able to swallow. Talked about all this. Patients who have GI motility issues or GI or pH issues, stomach contents versus no stomach contents might affect the way that the medication is absorbed and then distributed throughout the body. Endotracheal medications we don't really use. They are still in protocol for neonatal resuscitation because it's just really challenging to get an IV on a brand new baby. The problem is that it's not considered reliable because you might lose most of the medication to the tube, right, to that dead space of tube. You do need to flush the dose with sterile water, and you have to 2 to 3 times a higher dose than if you had given it just IV. For the most part, it's bronchodilators and anything that does mucolytic, which is just breaks down mucus. You can give like an albuterol treatment via an endotracheal tube if you're creative. You know, it can be done. Intranasal is super effective because you have in your nasal cavity here very like a lot of blood vessels, capillary beds, a lot of blood in this area, as anyone who's ever had a nosebleed can attest to. Super rapid absorption, just, you know, a mucous membrane is a really great way to absorb medication. 100% bioavailability, does not go through first pass metabolism. Certain scenarios, they do say it's better than IV medications. Most of the time it's Narcan situations, or like you need to sedate someone having a bad seizure and you don't want to necessarily take an IV out, you know, and try to start a line, which could be, you know, detrimental so much as you getting stabbed. Emergency medications preferred route is IV for the most part. 100% bioavailable, very fast onset of action within a few seconds. The problem with IV medication is you need to make sure that you are in a good vein. Okay, the infiltration risk, you can cause a lot of issues. D50 in particular can cause necrosis of the tissue if it does infiltrate into the arm or wherever your IV site is. Diabetics and drug abuse patients are notoriously hard sticks, as are patients who are in renal failure and like dialysis. Most of the time the dialysis is an issue because you only have one arm to work from, and they also have diabetes, so it's just troublesome. Profound shock is also, you know, patients, if you don't have enough fluid in your vasculature, they say your veins are flat, you might need to get, you know, I know it says large bore IV, but sometimes you might have to get a smaller IV first, get some fluids in them to even be able to find a larger vein. And that just comes with experience and kind of knowing what you're looking at. IV or IO, sorry, is pretty similar to the IV, almost the same exact onset. Depending on where your IO is, the humerus is a little bit faster than the tibia, for example. But again, onset of the medication is within a few seconds. Depending on the patient's age and how good their bone marrow is, you might require a pressure bag in order to push the fluid into the bone. Anyone who's had a fractured bone or has a fractured bone, you can't put an IO in that site. Anyone who's got severe osteoporosis, if you're working with just tibia, like the tibia IOs, if they've had a knee replacement, you can't use that leg because it's just, you're going to put it into metal. That's going to be a problem. Any sort of skin infection over the insertion site, because you're just going to put the infection right into the patient's bone, and they're going to have a bigger issue.
So with a patient who has cancer, right,
Mm-hmm.
would you have to be more careful when it comes to IOs?
Yeah. It depends on what kind of cancer also. I mean, if it's metastasized to their bones, I wouldn't even necessarily recommend it. But again, if it's like life or death, you might need to, but if the bone breaks, it's not going to be effective.
Gotcha.
IM medication, you don't use a significant less than 5 milliliters usually that you're going to be administering into a muscle. Depending on the size of the muscle, I think the deltoid maxes out about 3 milliliters of fluid that you could put into it. This is for the medications that you're like, this is urgent, right? Your epinephrines, Benadryl can be up there. Most of the time, it's almost 100% bioavailable. Again, it depends on what the blood flow to that muscle. So if you have somebody who is in profound shock, that IM medication is not going to be as effective. You also do need to make sure that it is an IM medication, right? This is why we have glucagon for those diabetic patients that you can't get an IV on, because you're not going to give D50 into a muscle. Knowing your landmarks is also an important part of giving these medications, because it's just, you don't want to hit bone. It's another lit kind of moment. Subcutaneous we don't really use. It's a little slower than IM in the grand scheme of medication administration. You see a lot of patients who are diabetics will give themselves sub-Q insulin injections. Women who are doing IVF, sub-Q hormone injections, okay? Just important to know, in so much as if you're taking the National Registry, sub-Q and IM can often be used interchangeably. We don't really give dermal and transdermal medications, but you may have a patient who has a fentanyl patch or something on. One of my most memorable calls that I've done was they called for grandma she quote unquote tripped and fell. I got in the house and the lady was like barely breathing, propped up against the kitchen cabinets, and I was like, "What's going on?" They're like, "Oh, she just discharged for a broken hip." And I'm looking and I'm like, "Is she taking any medications?" They're like, "No, she's been good." This woman had a fentanyl patch on her chest. And again, you talk about patient temperature, you talk about the amount of subcutaneous fat that's going on, right? She's a little skinny old lady. She got a super massive dose of fentanyl through this patch because of her lower amount of subcutaneous fat, and she went into an overdose. Nothing quite as exciting as waking grandma up with Narcan in the kitchen floor and her going, "What's going on?" And you're like, "We're going for a trip, ma'am." So make sure, right? You want to make sure that you check patients for dermal and transdermal medication patches. Behind the ears is popular, as well as on the chest. Sometimes the back of the shoulders is another place, or like the lower back. I know there's birth control patches. Those are like the commonly placed spots for it. And don't forget, if you do have a patient who has a medication patch, you remove it, wipe the skin, and make sure that you don't touch their medication patch. Sublingual medication, super quick absorption rate, so it will happen, like the onset of action is very quick, especially like things like nitroglycerin. But it's also usually very fast, a very short action of the medication. If your patient's mouth is super, super dry, that sublingual medication is just not going to work well. The mucous membrane needs to be moist. These are some of the most popular medications that we use on a regular basis, your inhaled and nebulized medications. Basically, the whole idea is that it's acting on the target tissue that you're applying it to, which is the lungs. So the lungs will absorb it directly and will be affected by it. A lot of the medications do have other interactions with the body. For example, patients who take a lot of albuterol will be tachycardic, right? That's a normal response. They might get a little weird and jittery from it, but that is expected. Rectal administration does not go through first pass metabolism, so many medication that was oral medications are not necessarily super effective rectally, because those we talked about before, those oral medications need to go through first pass metabolism because it's not the medication that's effective, it's their metabolites. Rectal administration is kind of unpredictable in terms of like when it's going to work and how well it's going to work, because there's a lot of other issues in the area in terms of like fecal matter and stuff like that that may prevent absorption. Not a super common route of administration at this time. Ophthalmologic is also great, right? People have boo-boos in their eyeballs. It's usually just anesthetics that we use. Medication has to get to the place that it's supposed to affect. So that's why Parkinson medications have been like limited in their success because you have what's called the blood-brain barrier, right? So your body tries really hard to keep certain substances out of your brain. So it's a very tight capillary suture, okay, right? The junctions in between are very tight. So, certain medications aren't going to be able to get through because your body's like, no, we like to live. The placenta is also, there's a placenta blood barrier as well, right? Because your body's doing a really good job of trying to keep this growing baby safe. Testicles as well, right? We want to make sure that we don't affect the spermatocytes and therefore create weird mutated babies. So a lot of the times, like for example, like carbidopa levodopa, which is a very common Parkinson's medication, it doesn't metabolize until it passes through the blood-brain barrier because the metabolites can't pass, but the original medication can. So that's kind of the way that they're working on trying to get around that issue. But it is a big problem for certain diseases. Sometimes your medication, depending on what kind of medication, it will attach to blood protein, right? So you have albumin, which is a huge part of your keeping your plasma inside of your blood vessels. The problem is that if the medication that you're taking binds to that protein, it can't make it to the target tissue because it really enjoys being bound, okay? It's got a little Rihanna thing going on. So if it is a medication that does bind really well to plasma proteins, you need a much larger dose in order to make it effective. This is why sometimes when people get older or people are like have poor nutrition statuses, that it might be drug dosing can be complicated. Fat stores medications as well. This is why amiodarone is such a potent drug as well, because it is stored in the body fat and has a very long half-life. So it's a very potent medication and it has a very, very long half-life, and it stays in your body for a long time because it just binds to your fat tissue. So it's up to like 180 days when you take amiodarone. It will still be affecting your body. In terms of volume, it's dependent upon your plasma levels. So if you have if you are dehydrated or you're in shock, the medication is not necessarily going to get where it needs to be. If you are well hydrated and otherwise healthy, the medication is going to kind of make it to where it needs to be. We talked about this already, but just a little bit clarification on metabolites. When a medication is broken down, it's been metabolized, right? So the two parts become metabolites. Sometimes they are very helpful, right? This is the idea. We want this one to work, and that's active, and it does what it's supposed to do. Sometimes it's harmful because it still does create side effects in the body. And then sometimes there's inactive metabolites, right? So it's broken down into like a null chemical that your body just gets rid of and isn't really concerned about. Different types of biotransformation. Just another little diagram to kind of give you an idea. So medication errors. This is a huge issue. Not only for us, but in the hospitals as well, right? They have a lot more checks and balances in hospitals than we do in the ambulance. So you want to make sure that when you are about to administer medication that you go through your list. One of the things that when the former instructors would say is you're going to check your medication when you pick it up, when you draw it up, and when you give it up. Okay, so remember that for lab, because you want to check, double check, and triple check that you have picked up the correct medication, that you have drawn it up from the correct vial, that you have the correct dose inside what you've drawn up, and that you're giving it to the right patient, right? So the right patient, right medication, right dose, the right route, the right time, right? If the patient is having an allergic reaction, but it's not anaphylactic, you're not going to necessarily give them epinephrine. You might give them Benadryl instead. The correct documentation, why you gave it, how you gave it, you're pretty much recapping all of the things you've just checked. What your assessment was that brought you to, the conclusion that the patient needs this medication. As well as your evaluation. The refusal, right? So a patient can refuse certain medications. There might be a patient who's having an allergic reaction who says, I don't want you to give me epi. I had a really bad reaction to it last time. It made me really jittery. And you're going to say, well, ma'am, that's a normal side effect, but this epinephrine is going to save your life from your anaphylactic reaction. No, I refuse. You give me Benadryl or something else instead. Okay? So these are things that you need to make sure that you are checking, that you're assessing, and then you're documenting. So sympathetic drugs are drugs either that simulate or block the reaction of your sympathetic nervous system, right? Your fight or flight response. Little ways to help you remember what the different ones, the different types of medications do. Alpha medications constrict, and beta medications dilate. Okay. Beta 1 medications usually work on the heart. Beta 2 medications usually work on the lungs because you have 1 heart and 2 lungs. Okay, that's pretty much what you need to know. If you also remember that beta blockers work on the heart and reduce the your pulse rate, that can help you if you somehow blank out on the ABCD trick. We use various medications in order to manage an airway. Commonly we use etomidate. Etomidate is a fast-acting sedative hypnotic. We usually pair it with benzos, because benzodiazepines have a amnesiac effect, so the patient kind of forgets the fact that you knocked them out and then stuck a tube down their throat. And it also keeps them nice and relaxed. Ketamine is a really, really potent dissociative, which can put patients way into la-la land. You also have your chemical paralytics, which they are very commonly used in the ER. I know Suffolk has these for RSI. You have your rocuronium and your vecuronium, among others. Those are your 2 most popular. And they do different things within the body. But we're going to talk about that more another time. Beta 2 agonists, these are the ones that are usually used for your asthma attacks, right? So you have 2 lungs, they want to work on both of those. So they, most commonly we use albuterol. Terbutaline is another one that almost, for some reason, they just love to ask about on the state test, because terbutaline can be inhaled or can be in pill form. So they get their jollies on asking people about terbutaline, but I have never ever seen terbutaline A on an ambulance or B being used in an ER. So I think they just kind of think it's fun. Most of the time when we're dealing with patients who are having an asthma attack or something to that effect, we also pair it with mucokinetic medications, right? So your Mucinex, we want to keep that mucus up and out. Steroids, right? Your Solumedrol and stuff like that. And leukotriene blockers, which I don't have a good name of one of those off the top of my head. Advair, there you go. Leukotriene, like the Advair and stuff like that, their work here to keep the mucus influx in the asthma attack from making the patient worse after they are feeling better. Antidysrhythmics come in in 5 different classes. First one is your sodium channel blockers. It's class 1. It's the 2 common ones that we see are the procainamide and lidocaine. There's 1A and 1B. They just work slightly differently from one another. Class 2 are your beta blockers, commonly seen for chronic high blood pressure and dysrhythmia control. You have metoprolol and carvedilol. Your class 3 are your potassium channel blockers. The most commonly seen one is amiodarone, though amiodarone does also have some calcium channel blocking qualities as well, but it's primarily considered a potassium channel blocker. And then you have your calcium channel blockers. You have cardizem, aka cardizem or diltiazem, that's the same medication. We carry that one on the truck. Verapamil is another one that you see patients usually commonly on, like long-term chronic. And then you have class 5, which is your quote-unquote unclassified. It's really just adenosine, because it doesn't work like any of the other medications, so it gets its own class. We use adenosine for the termination of supraventricular tachycardias. Different groups of antihypertensive medications. You have your alpha-2 receptors, which is clonidine. So alpha-2 dilates your peripheral vasculature when you agonize it. So you basically are making your container larger. Problem with clonidine, it could cause a lot of headaches and stuff because now you're dilating the blood vessels in your brain as well. But it's super potent, okay? So a lot of patients who take clonidine, they're on very, very small doses. It's like a 0.2 or something like that, and that'll tank their blood pressure like 40 points, okay? Especially patients who just start it. Labetalol is considered an antagonist for alpha-1, beta-1, and beta-2, which is why it's not very commonly used anymore because it's not specific to just the heart. It does have effects on the lungs as well, so it doesn't really, it's a little too broad of a drug, so they like to have a little bit more specificity. ACE inhibitors are ones that you're going to kind of see patients on in long term. So basically what happens is when your kidneys think that your blood pressure is too low, they will release angiotensin 1. And then your body uses ACE to turn angiotensin 1 into angiotensin 2, which then turns into aldosterone, which then causes your peripheral vasculature to constrict and raise your blood pressure because your kidneys are all about making sure that they get blood. So basically when you have an ACE inhibitor, it kind of steps in here and it's like, yeah, no, we don't need to be that high, guys. Like, let's calm down. Okay? So it prevents angiotensin 1 from turning into angiotensin 2, so it never gets to the significant amount of peripheral constriction that you'd otherwise see. There are angiotensin 2 blockers as well, which is a losartan, but I do believe that they just took that out because it was causing cancer. So we probably won't see ARBs as commonly. Isosorbide is a fun medication. It's a vasodilator. It is literally extended release nitro. So just keep that one in the back of your mind. That one a lot of people take as well. So Rob, we were talking about this a little bit before. We were talking about how Plavix is used in terms of keeping patients after MIs and strokes kind of safe. That's over here in the antiplatelet realm. That's why they have your grandma on aspirin and Plavix. Meanwhile, anticoagulants we're just preventing the coagulation. So on this side, the antiplatelets is keeping the platelets from aggregating, where anticoagulation is it's stopping the entire coagulation chain. Okay, so here it's just reducing how much clotting is going to happen, and here it's just like, yeah, no clotting, not at all, nothing at all. Keeping the platelets from being sticky, just bleed. Fibrinolytics are kind of after the fact, right? The TPA, you already have a clot, and now we're going to dissolve the clot.
There's other similar drugs to TPA, right? That you can get prescribed regularly, right?
Sort of, yeah. Usually it's heparin or the low molecular weight, Lovenox, that's it. The low molecular weight heparin. Your body actually naturally makes heparin, which is kind of cool. It's part of the whole reducing, like after you heal, like getting rid of clots.
Yeah.
There are people who are at risk for DVTs and such that they will put on Lovenox, which is a subcutaneous injection, and it works similarly to a TPA where it can break down existing clots, but it's not as potent as TPA.
So somebody who's prone to clots, usually it just has to do with hyperlipidemia combined with the hypertension and then a history of whatever other types of clots, or is there like a genetic factor or a molecular factor that predisposes or makes somebody more at high risk for clotting?
So some of the high risks for clots are like inactivity, right? So bedbound patients are always going to have a higher risk. Peripheral vascular disease can create risk. So like if you have just a narrowing of vasculature in general, because now if you think about it, you're slowing down how effectively the blood can get through an area, and it gets like pools and it starts to clump. There are some hypercoagulable situations a patient might be in. So patients who have certain cancers might actually coagulate too much, which is the hypercoagulable section of that issue. There's genetic issues that cause just like overclotting, but it can be a variety of different things. Yeah.
Okay.
Diuretics, we see this very commonly in hypertension control as well as congestive heart failure control, right? We want to reduce the amount of volume that is being pushed through the heart, reduce any potential for pulmonary edema. Lasix is the most potent of them. It works on the loop of Henle, which we'll talk about in nephrology. Kind of one of the everyone can have it, we really don't worry, is the hydrochlorothiazide, which is just fun to say. Potassium sparing, spironolactone. Hydralazine also has a vasodilation, so it can be used as a solo hypertensive treatment because it does diurese you as well as dilate your blood vessels. Opioids are fun. I think we have a pretty strong base knowledge of how opioids work, right? So this is in the brain is called the mu receptor. It's commonly found in the pain and pleasure part of the brain. The morphine will bind in the mu receptor and hang out and cause increase of dopamine and serotonin. It'll also create that which causes that happiness feeling, and it also can reduce respirations and such, as we're familiar with. Histamine is kind of fun. So your body has two different types of histamine. You have your histamine 1, which is just in your blood vessels, and then you have histamine 2, which is primarily inside your GI system. So medications like Zantac are often given to patients who are having allergic reaction secondary to like having eaten something, right? Benadryl is the more generic umbrella use that we give to everybody, but you'll commonly see like if you do like your ER rotations, like they might kind of do these two together. Zyrtec is also an antihistamine, which is really useful. Not as potent as Benadryl because it doesn't make it quite as sleepy.
Fun fact about Zantac,
Mm-hmm.
I just watched a commercial last night where they're doing that whole, if you were taking Zantac and you've been diagnosed with cancer.
Oh, good.
So, just a fun fact to throw out there.
Delightful. That's very exciting. I'm so happy to know that everything gives you cancer. So glucagon is, again, is a naturally occurring hormone in the body, produced by the pancreas. Again, we'll talk about that a later time. But the whole point of glucagon is it converts glycogen, which is how your body stores sugar, and it converts it from glycogen into glucose. It can take a little bit of time to actually work, so I haven't had a lot of success with glucagon in terms of like actually helping patients. I think one of the few times I've seen it, I've used it, the patient's glucose went from 12 to 15, and I was like, ooh, how exciting. Glucagon is also used in beta blocker overdoses because it does produce cardiac effects, where it increases the heart rate and the speed of electricity moving through the heart. But it bypasses the beta blockers, which is why it's so effective in beta blocker overdoses. It just stimulates the muscles themselves. Oh. All right. How we doing, guys? After that massive knowledge dump.
Splendid.
You good? Let's see. How many?
Yeah,
Hanging in there.
Hanging in there? All right.
still here.
Still here. All right. I'm just gonna show you a couple of the pictures in this other slide because we covered the majority of this already. And some of it's just good to know. So yeah, medication administration. Again, you're going to do a lot of this stuff when you're back in the labs and all that, so I'm not terribly concerned about you understand or you mastering the skill, but it's more of understanding the concepts behind it. We talked about the 6 rights. Discretionary orders are kind of the idea behind them is that you know how to do a medication, right? So you know how to administer an IM medication or an IV. You just might be using it in a way that you are unfamiliar with, right? So best one is glucagon. Glucagon we use for patients who are hypoglycemic. However, we just talked a little bit about how we can also use it for patients who are having a beta blocker overdose. If you have a patient, you're like, hey, doc, listen, I'm pretty sure this patient accidentally overdosed on their beta blockers. I'd like to give them glucagon and calcium and dopamine. They can approve that because it might be a quote-unquote off-label use because it's not in your protocols, but it is an approved way to use the medication and you know how to administer it. As opposed to like discretionary orders if they say, hey, go do a C-section, when you're like, yeah, no, that's not okay. Medical direction is also really good if you're like, I am not 100% sure what's going on here. I need some guidance. Had a patient once who looked like she was having a seizure, except for the fact that her eyes were open and she was following us around. She was kind of distorted into this like really twisted shape. And I was like, this looks like it might be a dystonic reaction. I called. Doctor said, yeah, that sounds like it. Give her Benadryl. And boom, pop right out of it. Kind of cool. We spoke about this already, right? You want to make sure you check all your medication issues, one way or the other, the concentration, the name, that you've picked up the right vial. Check with your partner because we don't do that enough. Medical asepsis, okay? You want to make sure that when you're starting a IV or you're doing IM injection that you are doing so in a clean setting. It's not going to be sterile. We know it's not going to be sterile. But it should be as clean as possible. Fun little fact, isopropyl alcohol does not actually kill bacteria. It is a bacteriostatic. So what it does is it literally paralyzes the bacteria from multiplying, where iodine kills bacteria. So even if you have that bacteria and it's brought into your system, you know, as you start an IV, it's not going to be able to replicate because you have now completely paralyzed it with alcohol. It had a good life, got a little drunk. So yeah, so we use clean technique. It's clean, not sterile. Standard precautions.
Nicole,
yeah, go ahead.
I'm sorry. So how come we don't, or they haven't developed any little iodine patches versus alcohol patches to clean the area?
Higher rate
like,
of allergy.
Oh, gotcha.
Yeah. Hand washing. There you go. Standard precautions, hand washing. We're not going to have to beat that to death. Don't recap needles. Just put it right in the sharps container. Do your invasive procedures on scene, okay? You shouldn't be doing it while you're driving around. It takes approximately 30 seconds to start an IV if you are efficient and you practice. You don't have to do that while you're moving. There is never really, there's like maybe 0.5% of times where you might have to do that while you're moving. The most likely thing that you're going to do while trying to start an IV or administer IM medication while you're moving is to stab yourself, and that's just a lot of paperwork. Body fluids, right? We talked a little bit about electrolytes the last class, right? We got our good idea of what those things are. Your body fluids, right? We're about 60% water, and that water is broken down further into, just the solutes that are inside of it. Your electrolytes, we talked about this already. Know how fluid moves, right? So you have diffusion where if there's a high level of solute on one side, that the water will move across to dilute it, as opposed to water moving across the cell. Or sorry, diffusion is the solutes moving. So like your ions are moving back and forth. Osmosis is just water moving. Filtration is done by the kidneys, right? It's under pressure. So you're pushing fluid through something in order to create that movement of fluids and electrolytes. And active transport is commonly seen with glucose, right? We use insulin to move glucose into a cell, and that requires energy. ATP is used. Only thing that can replace blood is blood, okay? We can kind of bolster people up with saline in the meantime, but ultimately they are going to need blood. Different things that we use, most of the time we're here in the crystalloid department, right? So it's dissolved salt crystals usually in water that can change the fluid levels. Colloids are large molecules, usually albumin, okay? That's a hospital thing. We use isotonic crystalloids, right? So it's about the same concentration of sodium as the cell, because if it's hypertonic, that means it's a very high concentration of sodium that's going to draw water out of the cell. If you use hypotonic, it's a low concentration of sodium, so it's going to push salt out of the cells to create equilibrium. There we go. So the different ways we want to be here in this happy medium. 3-to-1 rule. This is every once in a while. You'll see this on the state test. This is a popular one. 3 milliliters of fluid is needed to replace 1 milliliter of blood. And that's just from a vascular perspective, not from an oxygen transportation perspective. So, state question. If you give a patient 1 liter of fluid, after an hour, how much fluid is still left in their vasculature? Yeah, bring back math, guys. I've lost you all. It's about 300.
Well, they have a $5 service fee.
All right, so if you put in 1 liter,
Just do it anyway.
after about an hour, only 300 milliliters of that is going to still be in the vasculature. The rest of it's going to go extravascular. There you go. There's your answer. We talked about this already, macro versus micro sets. There are a variety of ways that you're going to choose an IV site. Joints are bad. Like we usually use the AC right here. The basilic vein is very popular. In larger people who may be a little obese, the cephalic vein on the outside of the arm is often very easy to find. But you can find almost any vein. Every once in a while, you can go down to a foot. Foot's just like a hand. Got to make sure you watch your angles, and again, we'll talk about that in a little bit. Don't start stuff directly over a joint, because the second the patient bends the joint, they're going to kink off the IV, and then it's not going to give them the fluid that you're trying to do. Patients with severe edema or have had a mastectomy in that arm or on that side, really not a good place to start an IV, and dialysis fistulas are a no-no. EJs you might not get a flashback on. You will be in, but it's so high pressure that it's not coming into the chamber. You want to make sure there's no air going into that chamber, because you will give the patient an air embolism. And you also want to make sure that you didn't hit the carotid artery. You are, in fact, in the EJ. This is a very easy access site in patients who have congestive heart failure or JVD, right? Because you're going right into that blood vessel. Sometimes you might have to start a smaller IV on the geriatric group. They have very, very delicate vasculature. Hands are sometimes a little more easy because you can kind of pull the skin out of the way and get yourself right to where the vein is. But it's very common that if you put too much, like if you push the flush too fast, you'll blow the line. So you have to be very gentle. And also, if you're going to do something like a KVO or something with an elderly person, I would recommend using a micro drip because macro drips can run away from you. So we call it a runaway IV bag, and where you're giving them more fluid than you really wanted to. And then you can cause, pulmonary edema and other issues. Don't ask a patient what their favorite color is. That shit makes the news. When you're doing an IV, always make sure that the bevel side is up. You're going to, and this is going to be, you're going to be learning this in the lab, but the constricting band should only restrict venous circulation. And you want to make sure that you keep good traction on the vein to keep it in place so you can poke it, okay? While, yes, 14 gauges can administer more fluid, and I think, Joe, you asked about how much a macro drip can give, it's also going to be limited by the size of the IV that you have, right? So your coffee stirrer of a 14 gauge can give up to about a liter every 4 minutes. However, it also depends on the length of the catheter. Somebody said that there's like a fire hose once, but if you have a longer hose, you're going to have increased friction on the way into the blood vessel, right? So even though the opening might be wide, if it's a very long 14 gauge, it's going to be slower. So sometimes because a 16 gauge isn't as long, it might actually run faster than a very long 14 gauge that you might use for needle decompression. We're going to just kind of breeze through this because you're going to do this in labs as well, but you want to make sure that you flush your IV tubing out. You put the pointy bit into the chamber. You want to kink off the tubing so that you can fill the chamber about halfway, and then you are going to run it through and make sure the air bubbles are out of the line. Always make sure that your expiration dates are good. Check your administration set. Make sure that you've taken the VCB off. That's always an issue. And if there's an issue with running fluid through it, you want to make sure you also check the IV site because you may have accidentally infiltrated the patient. You might have put it in their AC and the patient's got their arm bent so that they essentially have kinked off the IV. A lot of different things, but again, you're going to do a lot of these things when you get into the labs. That is not a good sign, okay? A lot of different local reactions, right? If you hit the artery by accident, you're going to get that pulsing blood, which is not good. You can hit nerves and tendons and such that are in there and cause a lot of pain. You can infiltrate the vein and cause a lot of just edema because you're trying to push fluid in. Thrombophlebitis is this irritation of the vein that the IV is in. That's probably one of the most common side effects of an IV. Systemic issues as well. Sometimes people do have a pyrogenic or an allergic reaction, right? They'll spike a fever or have an allergic reaction to something that you've given them. You can cause an air embolus if you don't flush the IV tubing out appropriately. If you don't start the IV appropriately, right? So you put that little plastic catheter in and then you're like, oh, I'm not in. You pull it back over the needle. You can shear it and create essentially give a person a stroke by sending this little piece of plastic through their system. And sometimes people will vasovagal out. One of the best ways to get rid of SVT is to tell a patient that you're going to start a large bore IV. They bear down and they fix it all on their own. This is why IOs work. So you're putting a needle directly into the bone marrow, and the bone marrow is has a lot of vasculature, right? Because that's where baby blood cells are made. So it needs a way to do that. You might need to give an infuser. We pretty much stick here in the city with a tibial tuberosity. The humerus is also appropriate, but personally I don't like the humerus because I think it's just too much flopping around. It's a little easier to secure a leg, but that's just me. See? No bueno. This is when you start an IO and it extravasates. Not good. If the fluid doesn't run well, you'll end up with edema. You can break the bone. You can go all the way through the bone. This is like the through and through. You feel pop, pop. You can send various pieces of bone or fat or blood, bone marrow through. You can damage a growth plate in pediatrics. Most of the time, osteomyelitis, which is like an inflammation because you just essentially stuck a freaking needle in the bone. These are some of the issues you can have with IOs. Don't put an IO in that. We were talking about various issues before, what you don't want to do. This is osteogenesis imperfecta, which basically the bones don't grow appropriately. So you'll know. This will be in their medical history. You're going to look at that bone and go, I'm not putting a needle in that. We talked about these things already. Just do know the difference between enteral and parenteral. Okay, enteral, just think enteric-coated aspirin, right? It's enteric-coated to protect the GI tract because you're going to be taking it through the mouth. Okay, so if it's going through the mouth, the rectum, that whole, GI system, it's enteral. Parenteral is anything outside the GI tract, so IV, IM, sub-Q. Percutaneous is absorbed. Inhalation, we all know. Talked about endotracheal already. We were approved in the city a few years ago that you can access a PICC line if the patient is in severe shock or cardiac arrest, but you can't do any of the like a central line or anything else. We can do PICC lines. Don't even touch AV fistulas. There's just too much potential for disaster. Different types of medication packaging, right? We have the ampule, the ever famous ampule, the little Bristol jets, the carpet jets. I hate these things. I always screw these up somehow. Could never get the little cap thing to work. Single dose vials. This one where it's a single dose vial, but you have to mix it, and then you have reconstitution, right? Your glucagon, you have to draw it up from here and put it in there. In order, because this has a longer shelf life than this. This and this have equal shelf lives because you're separating the liquid from the dry powder. Different ways that you're going to administer medications, right? So you kind of want to stick here in your intramuscular and subcutaneous, or really 90 degrees for intramuscular. When you guys do your IV labs, they're going to tell you, oh, 25 degrees. Not necessarily true. Depending on the patient's vasculature and how well you can see their veins, you might actually enter at a much lower angle and just kind of, like, not this flat where it's like completely against the skin, but not this high either. When you start this high, also, I don't know how he's holding this, like, what is this, a pencil? When you start this high, you're at a very high risk of going right through the vein. And if you go right through the vein, it's, not really accomplishing what you want to do. So again, you'll do this in labs. You'll develop your own skill set there. We talked about this before. You administer any medication via a needle, right, IV or IM, you should pull back on it to make sure that you're not, that either if you were doing an IV that you do have blood return, which means it's a patent vein, or if you are doing IM that you don't have blood return, because then that means you're just hot-shotting the patient. You don't want to do that either. You want to make sure that you clean your sites, either the IV port or the patient's arm or wherever it is that you're administering the medication. Rapid or slow administration is completely based on your medication, and this is stuff that you're going to learn. I would highly recommend looking through your protocols and kind of beginning to learn them, so that you understand, because this is the time when now you're going to put together what a medication does and how you're using it as a paramedic. So highly recommend looking through start to look through your protocols, your respiratory and your cardiac ones. Definitely going to be where you want to be. If you have to add, I know we talked about this. I'm going to mix amiodarone. There's a medication port, right? So you're going to draw it up in a syringe over here, and then you're going to kind of shoot it in through the medication port. Make sure you clean the medication port, and make sure that you label it. We talked about that already. Piggybacking a line means that you have a normal saline line running, that you've mixed your medication into another bag, and that you are going to now mix this medication bag. You're going to hang it a little bit lower than the saline, and then you're going to turn the saline off and then run the medication through the line. This gives you the opportunity that if you need to administer a different medication, like via bolus or something, and you only have the one line, you can turn off the medication that you're administering, flush the line effectively, and then administer the medication. IVIO is the fastest. Topical is the slowest. I think kind of beat this to death already. That's it. Cool. Okie dokie. Thank you for sticking with me, guys. It's a long one today. Sorry. Any questions, thoughts, or concerns?
Can we start practicing at home?
No comment. Anybody else?
I have a question in regards to like our discussion.
Sure.
I know you want us to use Google Scholar and answer those 5 criteria or whatever, but I'm finding that for mine, like a lot of mine it's more or less with Google Scholar. It's like obviously it's research and they don't have like that criteria. I'm actually finding that stuff on like NIH or whatever, but
that's fine. NIH is fine. That's an acceptable resource.
Okay, I just didn't know if like you wanted us to get something off of Google Scholar that is relatively like it's about our drug or whatever, and then briefly discuss that article, or
no, it was basically giving you like a resource, like, hey, like this is where you can find academic stuff. Like there's a lot of other places you can look also, but okay. I do want them to be like academic. Like if you do like look into a drug and like, oh, this is they just did a new research study on this one, and like they're using it for I don't know, rabbits or something, like it could be just helpful for learning purposes.
Okay.
Anybody else? Okie dokie. Let me stop this recording then.